So we have finished the pathophysiology regarding the heart itself. We went through heart rhythm issues, so Brady's and Tachy's. We went through how the heart remodels itself based off of high blood pressure, different valvular issues that can happen later on. But heart failure, the way the heart remodels itself, the cardiomyopathies. So make sure when you're studying left and right-sided heart failure, so your HFpEF and your HFrEF, that they're called now, preserved EF or reduced EF. Your cardiomyopathies, dilated, hypertrophic, and restrictive are the three cardiomyopathies. Make sure you understand those. Because remember, this is just pathophysiology. This is just the underlying cause of what's going on with that patient. When you get to all your medical courses, they're going to say this causes the heart to go into a dilated cardiomyopathy. Now you know what a dilated cardiomyopathy is as you're learning all those things. Then we went through all the valve issues. So make sure you know the 4 valve problems, the 2 aortics and the 2 mitrals. And make sure you understand the difference between HOCM and AS on auscultation and what you have to do to rule out one or the other. So the whole bearing down Valsalva. So those are the issues with the actual structure of the heart itself. Now we're going to talk about the vasculature and what can happen in the vessels and the role that they're going to play going backwards onto the heart itself. So the first thing we'll talk about is just coronary artery disease. Presentation, obviously they're going to have chest pain. It's the most common symptom, but not all heart attacks present with chest pain. Especially in women, they're not going to present with true classic chest pain. It may be a little bit different. Usually dull, and it also can radiate to the arm and the jaw. Does not worsen with deep breath. That is very important. So if you're having pain in the chest and you say, take a big breath for me, does that make the pain worse? Yes, that's probably not cardiac, because cardiac pain doesn't worsen with deep inspiration. That's usually going to be musculoskeletal because you're moving your rib cage. So if you have costochondritis, the inflammation of the cartilage on the breastplate, that will cause pain to happen. What questions should you ask a patient who has chest pain also? What are some other big questions you want to ask? How long? What about trauma? Were you hit in the chest for a reason? That's a reason that would cause chest pain. So figure out why are they having this chest pain. Can be associated with shortness of breath, diaphoresis, nausea, and vomiting. Break out into a sweat. So it can be. Not everyone has these symptoms. Diabetics, I mentioned a lot a little bit in physio. I mentioned a lot when we get to the diabetes part, but this autonomic dysfunction that occurs with long-standing untreated diabetes, blood pressure issues, hypotension, all the gastroparesis, the stomach doesn't move very much. Those are all autonomic dysfunction issues. So because of that, they may not present with shortness of breath or nausea and vomiting because they have this underlying autonomic dysfunction. So the whole complex, pain complex, is just called angina pectoris or chest pain. Classification, this is very important as well. If you call it stable angina or stable angina, whatever you want to call it, that means the chest pain only occurs with exertion and is stable over a period of time. So you have a patient walk, and after they start walking a certain distance, they start getting chest pain. That is related to the exertion. Once they stop walking, the chest pain goes away. The next one, unstable angina. This occurs at rest. They're just sitting there watching TV and they start getting chest pain. Okay, that's unstable angina. And the last one obviously is a myocardial infarction, that if this chest pain persists without interruption for a long period of time, you can get this irreversible myocyte damage due to the ischemia of lack of blood flow to an area. And if it goes for a long period of time, the tissue is going to die. So you have to know those 3 classifications of chest pain. Etiology, what are some major causes of coronary artery disease? The big one is your atherosclerosis, just normal plaques in the arteries. This is your build up those fatty streaks. Okay, risk factors: hypertension, high cholesterol, diabetes, smoking, family history. Start memorizing those things. The majority of what you're going to be treating is just these things. Why? Because we want to reduce the risk of coronary artery disease, strokes. Stroke is still a arterial disease. Okay. Other reasons: spasm. Okay, coronary vasospasm. If that coronary artery spasms and kinks and squeezes on itself, can any blood get through that? Nope. So that will cause some chest pain. But once that spasm relaxes, blood flow comes back and the chest pain goes away. Emboli is a very rare cause to have in the coronary artery. Because of the way the blood flows and it goes fast through that aorta, it doesn't have to turn that angle to go to the coronary arteries. It's very, very tight, so it's very rare, but it would have to be with a patient usually from endocarditis. They have a vegetation on that valve, and that little piece breaks free and it goes up into the left or the right coronaries. Usually it's going to go to the brain, but not. Sometimes it can happen that way. And the last one is a congenital. So obviously they're born with this. So they may have some congenital coronary abnormalities, and that can cause some chest pain as well. So the heart has a very high metabolic requirement. 7% of all the oxygen consumption just goes to the heart muscle just to continue beating and keep the energy going so it can do it. So because of that, it's very high risk for cell ischemia, lack of blood flow. And when you think about blood flow to the heart, think about it in two different ways. One, is there an increased demand of oxygen on the muscle? Okay, if they have ventricular hypertrophy, do you think that the metabolic requirements have gone up or down or the same? Up. Why? There's more muscle. It requires more oxygen. So the thicker the heart, the more oxygen it's going to require. Or, so is there a demand for oxygen? Does the heart muscle require more? Or is there a reduction in the oxygen supply? Is there an occlusion in the vessel that's preventing blood from going past that? Therefore, you're going to produce ischemia distal to the occlusion. Okay, most of the cases are due to decreased oxygen supply. An occlusion, the vessel diameter, or the radius, whatever you call it, is getting narrower, less blood can get through. What is the first line treatment for chest pain in the wilderness and out in the world? Nitroglycerin. What does nitroglycerin do? What does nitric oxide do? Potent vasodilator. So what are we trying to do? We're trying to dilate those coronary vessels to promote more blood flow to the myocardium. That's why we give nitric oxide first line. You can do 3 doses every 5 minutes to see if it relieves the chest pain. Cocaine, okay? If you go on a bender of cocaine, you can really do a lot of damage to your heart muscle. Cocaine really increases the oxygen demand on the heart. So they get a lot of chest pain, just cocaine, chest pain. Once cocaine's out of the system, the chest pain goes away. So atherosclerosis is the big one that we're going to be talking about, predominant cause. Now, atherosclerosis develops because there are little itty bitty tears that happen inside the vessel. Now, where they happen, it happens with everyone. In your 20s, you have some fatty streaks in your aorta already and some of your coronary arteries. It's there already. So what happens is increased shear stress. When we have vessels that have bifurcations in them, blood comes this way, it's going to hit that bifurcation, that little bridge, that fork in the road. So all this pressure keeps bombarding that area, and if you have high blood pressure, more shear stress is hitting that wall every single beat. Eventually, you're going to cause little tears in the vessel. And when that tear gets injured, or the vessel gets injured, that's when all of these little foam cells, the LDLs, the free radicals, can all get in there and start causing some problems. So progress progresses, you get foam cells, smooth muscle cell proliferation. The vasculature, the endothelium, is going to try and encapsulate that plaque. It's called endothelialization. So you have this streak, and I'll show you some pictures in a second, but the vasculature is going to try and smooth that over, regrow cells over it. So what happens, so here's our normal vessel. We have our nice endothelium layer right there. There's no injuries in this area right there. That's okay. So this is a normal cross-section of a coronary artery. Now, we have injury to the vessel. What is the first thing that happens whenever we have an injury to a vessel? What presents itself to fix the area? Platelets. So all these platelets get into that area to try and cover the damage. And eventually the clotting processes happen and all that stuff we talked about before. So platelets connect to each other, they start aggregating. So what medicine do we give to prevent the platelets from doing this in the coronary arteries? Aspirin. Okay, not blood thinners. Blood thinners are too slow. Your Coumadin, heparin, Lovenox, Xarelto, Pradaxa, all those drugs are for venous problems, slow-moving issues. Arterial problems need platelet issues. The blood's moving too fast. Remember, artery is very, very fast flow. Veins, slower flow. So we don't want the platelets to aggregate, because when they aggregate, they're going to make clumps. So if we have, here's our normal vessel. There's no damage. Everything is nice. Now, we've damaged the vessel. So there's the outside. And now we have a little bit of an occlusion going on. And this is all due to the damaged area in that vessel. Do you see how the diameter is getting smaller? So we have a plaque here. So let's go to the next slide. What's going to happen is, over time, the smooth muscle starts to migrate and encapsulate and make a cap over all these foam cells and the injury, and it kind of seals it out. But it doesn't go back to its normal size. It just like, I don't know, if you have a big mound of dirt, you just put some grass over it. The mound is still going to be there. You just put grass over it. But the dirt's all there. The problem now is with high blood pressure, uncontrolled cholesterol, smoking. If this plaque ruptures, if it cracks, we re-injure this area, so what's going to happen again? Platelets are going to come right back to the area and try and fix the damage. So what happens is, now our vessel size is almost like that now, because the plaque keeps getting bigger and bigger. And then you have another plaque rupture because you're not taking your medicine, your blood pressure is very high. So now, maybe this is all that you have left to get blood through. This one little area, and that's it, because all of this is plaque in the artery. So the surface area, what you can get blood through, reduces and reduces and reduces. If it gets to a certain percentage reduction in vessel diameter you get blood through, you start getting chest pains. And we'll go through that in a second. So here we are. In patients who have stable angina, what's stable angina? Exertion. The lumen, the size of that vessel must be decreased by 90%. 90% occlusion of those coronary arteries, where you'll start getting chest pain at rest. However, what we do is we do stress tests. We do exercise stress tests, or we can do chemical stress tests. If people can't go on a treadmill, we give them a chemical that makes their heart rate go really fast. With exercise, a 50% reduction in the coronary arteries will produce chest pain. So if you put them on a treadmill and you say, okay, we're going to walk on a treadmill, and every few minutes the speed and the grade are going to get faster and more steep, and you're going to have to walk against it and keep going. Every 3 minutes, it goes up and up and up. And let's say after like 9 minutes, your patient's like, oh, I'm starting to get some chest pain now. Well, look at the EKG and see if you see any EKG changes. But if they have 50% and they're getting chest pain on a stress test, it's a very high likelihood that they have coronary artery disease. And now you have to go into the next step, which is a cardiac catheterization to actually see what's going on with the coronary arteries. So stable angina, 50% reduction in lumen in exercise will produce chest pain. That's why with exertional chest pain, it happens whenever they exert themselves to a certain intensity. In patients with unstable angina, fissuring of the plaque, that plaque rupturing, it cracks again, lead to platelet accumulation. That's why we give aspirin or Plavix. They both are antiplatelets, but aspirin is obviously cheaper. And transient episodes of thrombotic occlusion, usually lasting 10 to 20 minutes. So they'll have some transient chest pain because they have these little occlusions causing the pain to occur. We also have, because of platelet activation, we get this thromboxane A2, serotonin, may get some endothelial dysfunction going on from all these things being released due to the platelets. That will further cause vasoconstriction and further contribute to the decreased blood flow. Just remember, the heart is a muscle. It needs blood supply as well. Don't worry about, the heart is going to pump the blood out to the body, but it's still a muscle and it still requires blood supply. In a myocardial infarction, that plaque rupture, deep arterial injury, presents a relatively fixed and persistent thrombus. Okay? Fixed and persistent. It's fixed. That artery totally occluded itself due to the platelet aggregation in that area, due to the repeated intimal injury, due to high blood pressure, due to smoking, uncontrolled diabetes. These are all vascular issues. They really shred. Anything that shreds up the inside of the vasculature is going to cause plaques to form. Because you cause an injury to the intima, it's got to repair itself. We talked about how we repair. It's going to cause that problem. And it's going to repeat over and over again. Heart gets its ATP by oxidative phosphorylation. Within 60 seconds after coronary artery occlusion, the O2 tension essentially falls to zero. There's no more oxygen in that blood going to that, or in the tissue, nothing to feed the muscle cells. Those cells are going to start dying off. So we have our cardiac stores of these high energy phosphates that help to replace the phosphate on that ATP cycling all the time. So we shift to an anaerobic metabolism, and whenever you hear anaerobic metabolism, think lactic acid. That's the byproduct of anaerobic metabolism. What does lactic acid also cause in your muscles? Soreness and pain. So you're getting lactic acid building up in the cardiac muscle, causing the pain to go there as well. Dysfunction of myocardial relaxation and contraction occurs within seconds. That's why I always say time is tissue, whatever, time is brain, time is heart muscle, because you got to get them, you have to reopen that vessel as fast as you can to prevent the necrosis and the infarction of those dead tissues. If perfusion is not restored within 40 to 60 minutes, irreversible stage of injury occurs. If the ischemia myocardium is perfused within 5 minutes, systolic function returns promptly, whereas the diastolic abnormalities may take a little bit more time to return back to normal. If they have these prolonged episodes of ischemia, up to almost an hour of these during the event of the myocardial infarction, sometimes it takes up to a month to restore ventricular function, and that's called a stunned myocardium. How would I know that they have a reduced ventricular function? What am I looking at? Ejection fraction, and where do I get that from? Echocardiogram. Start thinking, Where am I going to get this result from, and how do I get it? What test do I need to use to get these results that I need? So what I said here was, when your EF is less than 35%, you start getting into a high risk of developing a bad lethal ventricular arrhythmia, ventricular tachycardia, or even worse, ventricular fibrillation. But because we know it's a stunned myocardium, the function may return in time, we give them what's called a life vest. A life vest is basically a couple of straps that you wear on your skin, and it acts like a defibrillator, but it's external. It's not inside yet. And we leave it on for 3 months with great medical management after that heart attack. After 3 months, we repeat the echo, and we see how the echo is doing. How is the EF? Is it improving? If it improves back to normal, we can remove the life vest because their risk of sudden cardiac death went down because their EF returned. But if the EF is still in the 30s, then we'll recommend that they get the implantable cardio defibrillator, the internal one that will protect them all the time. So that's what I was saying here with life vest versus AICD. Because we know this phenomenon with a stunned myocardium, it takes time for systolic function to return with a prolonged MI. And if reperfusion occurs later or not at all, sometimes systolic function may never return. So, clinical manifestations, chest pain. Why are they getting chest pain? 70 to 80% of ischemia are still asymptomatic. So chest pain does not mean it's going to be a heart attack. When present, when they do have chest pain, it's your sympathetic afferent fibers. Remember, sympathetic is always the pain stuff with regards to impulse and how you sense it. We talked about in neuro how we have overlap of our nerves and when they connect into the spine. So sometimes our brain will mix different areas together. One of them is our esophagus, the chest pain, the neck, the arm. It radiates these areas because of this crosstalk with the nerves. And they all get confused, and that's why you feel pain in different areas. They think it's adenosine that actually causes the nerve pain to happen. As far as why people have asymptomatic episodes, here's your autonomic dysfunction, dysfunction of the afferent nerves. They're not working well. Transient reduced perfusion, it wasn't long enough. It was just a little bit, and then it came back. It wasn't enough to produce enough of a chest pain. Also, differing pain thresholds. People experience pain different. Some people, they get a little bit of a pain, and they start freaking out, going crazy, I'm dying. Some people literally are dying, and they'll be like, I'm okay, I'll stay home. Because their pain threshold's like, well, it's not so bad. So everyone experiences pain differently. That's why we try and rate it on that scale of 1 to 10. How bad is your chest pain? So you get a way to quantify their chest pain. Fourth, heart sound and shortness of breath. Again, remember, when you have an infarction, you're going to alter your systolic and your diastolic function. You're kind of like putting a pseudo heart failure going on in that patient immediately. So they get some heart failure symptoms because they need an atrial kick now for that fourth heart sound. So start getting that fourth heart sound. What is it? Atrial kick. Why? There's a filling problem, and we need the atria to help the heart fill. That's the diastolic problem. And obviously the systolic dysfunction because the heart's not going to pump out as much anymore. So you have filling issues, you have squeezing problems, you are causing heart failure symptoms because you're destroying the contractility. Shock is another symptom that may happen with chest pain. Okay, the more myocardium that is supplied by the occluded vessel, the more significant and severe the symptoms. So know your anatomy. On the left side, what's the first part of the left coronary artery system? Go higher. The left main coronary artery, right? If I occlude okay, so here's your circumflex, LAD, left main. If I occlude left main, this whole entire area is out. You see why? Now, if I occlude the circumflex, only that area is out. So the more distal you go, the less severe. That's why the left main is considered the widowmaker, the LAD essentially. You occlude left main, the whole left ventricle is not squeezing very well at all. The whole anterior part of the heart is gone. So that's what we're talking about with regards to all that. Let me clear the page. Okay. So again, if you occlude the left main, you get the LAD is out, and they're going to be in shock with that. So usually if they're in shock with the MI, it's due to left main issue, the LAD. Okay. If necrosis of the septum occurs due to LAD artery occlusion, they may have some intraventricular septal issues can occur. If they have rupture of the anterior and lateral free walls from occlusion of the LAD or circumflex, they can develop pericardial effusion and tamponade. They actually rupture the free wall of the ventricle. There's a hole in it now, and blood is leaking into the pericardium. Fluid should not be there. We'll talk about that in a little bit. Rupture of myocardial tissue usually occurs 4 to 7 days after the event. You have to let that tissue die. It takes time, and as that more and more cells die, it gets weaker and weaker and weaker. So it takes about a week later, and then you may have some issues happening. So if someone had a heart attack and a week later, they start getting some episodes of like heart failure, shortness of breath, issues like that, look at them, do an echo, see what's going on. They may have ruptured part of the wall. The chordae tendineae may have ripped off. The papillary muscle may have ripped off due to the necrosis of where the occlusion occurred. Circumflex occlusion, again, here's your papillary muscle. And if you rupture the papillary muscle, severe MR and shock. They go right into MR, acute MR. Bradycardia. If a patient has an MI and they also have bradycardia along with it, it might be what's called the inferior wall MI. And remember, the inferior part of the left ventricle is supplied by the right side of the heart in like 80% of the people. Okay, so the artery that provides blood to the AV node branches off of the PDA from the right side of the heart. The AV node is only supplied by that one artery. So you put them in an AV block, which will cause the bradycardia. The SA node is actually fed from the left and the right. They both have septal branches. They both supply the SA node. But the AV node only has one supply, and it's from the right side of the heart. So if someone comes in with an inferior wall MI, you see ST elevations in your inferior leads, 2, 3 AV and F. And they have a really, really low heart rate, an AV block. They may have an inferior wall MI due to the right coronary artery being occluded somewhere along the route. Nausea and vomiting, vagus nerve gets activated, especially in an inferior wall MI. Tachycardia can also happen as well. This is usually due to the catecholamines, due to the stress response of having a heart attack. Your catecholamines are going crazy, your epi, norepi, so your heart rate's going to go up, your pressure goes up, trying to overcome the stressful environment. Okay. Okay, so that's it on the coronary artery disease. Now we're going to talk about pericarditis. Okay, pericarditis, now we start talking about symptoms. With patients with pericarditis, it's the inflammation of the pericardial sac. As the heart is squeezing inside that thing, it's irritating the pericardium every single beat. Okay, sharp retrosternal pain, worse with deep inspiration or coughing. So I mentioned before, coming with chest pain, have them take a big breath in and out. Does the pain get worse? Yes. Pericarditis is one of your diagnoses now. It can also be just if you have the flu and you're coughing like crazy all the time, you'll probably had chest pain from breathing in and out just from coughing so much. Or pleuritis, just inflammation of the pleura surrounding the lungs will also make you have chest pain with inspiration. But with pericarditis, it's position dependent. They're going to be leaning forward because as they lean forward, the pain gets less and they feel better. So when you go into the room and see this patient, if they're sitting down and they're tripoding, their hands in front of them because they're leaning over, start thinking, well, maybe they have pericarditis as a reason for what's going on. So on physical exam, they have what's called a pericardial friction rub. It's a high-pitched squeaking sound. It's a continuous murmur, meaning you'll hear this in systole and diastole. It's like a squeaking. It's like a squeak, squeak, or a rough, friction, like a rubbing, but it's happening through systole and diastole because as the heart squeezes, the pericardium is rubbing against it. When the heart relaxes, the pericardium is rubbing up against it because it's inflamed. So it causes a continuous, a to and fro murmur, pericardial friction rub. Those are all things related to pericarditis. If you have continuous inflammation of that pericarditis, remember pericarditis, inflammation, if the inflammation becomes chronic now, it can lead to fibrosis. And if that happens, it can lead to what's called constrictive pericarditis. That pericardium becomes very rough now and very tough and won't move very well. The heart won't be able to fill very well because it can't expand. Because you're trying to expand against like a straitjacket. It's like a restriction to the heart. JVP is going to be elevated because the heart can't fill very well. If the heart can't fill, where are you going to back up? Into your IVC, SVC, because the heart can't fill properly, so everything gets backed up. The lungs, the body, so your JVP goes up with pericarditis. Okay. The other thing is this Kussmaul sign. When we breathe in on a normal inspiration in normal healthy people, what happens to right atrial pressure on inspiration normally? Should it go up or should it go down? Right atrial pressure goes down when you breathe in. Remember, we breathe in. Preload goes crazy because that's like a suction and pulls all the blood right back in. With pericarditis, they have what's called Kussmaul sign. Kussmaul sign is now, it's an increase in right atrial pressure with inspiration. So it's the opposite. They get an increase in right atrial pressure when they breathe in because the blood is still there and now you're adding more to it. So it goes crazy. Some causes for pericarditis. Infections are the big one. Here's your Coxsackie virus. You start learning about all these fun bacterial stuff in microbiology in the fall. But just know that those type of bugs can cause these types of infections. Collagen vascular disease, neoplasm, metabolic injury, and so forth. So these are just different causes. But the big one is the infectious. Usually asking, were you sick recently? Did you have a viral infection a week or two, month prior to you coming with this chest pain? Ask about prior illnesses, especially with pericarditis. So when you look at the breakdown and you actually look at the pericardial stripping and you look at the tissue, obviously they're going to have inflammation, leukocytes will be there, increased vascularity, all things that are going to happen due to the inflammation. If it's long, it becomes fibrotic and calcified. A lot of calcium. So whenever you hear calcium again, think it's been there for a while. It takes time for calcium to do its thing. And obviously, the more fibrotic it is, it alters the filling of the heart. The compliance is altered. Diastole is altered. Remember, diastole, compliance, filling. These are all not interchangeable, but they're all related to a filling diastole issue. So when that happens, you get those constrictive pericarditis. Clinical manifestations for pericarditis, they're going to have chest pain as well. So now people come in with chest pain. Now we got coronary artery disease. Now we got pericarditis as two diseases that present with chest pain. But when you go to listen to that heart, more often than not, they're not going to have a new murmur with a heart attack unless they ruptured something. But for the most part, again, if you hear the murmur throughout the entire thing, and let me pull this one up. Okay. So this is pericarditis. You hear how it's all the time? It's continuous in systole and diastole. It's in both. That's pericarditis. I'll play it again. So you have to listen to these things. In PD, when you guys get to the cardiac section, we have a mannequin that you can program what heart sound you want to hear. So like you can program it and your partner can listen and see if they can know what you're talking about. So that's the friction rub that we just talked about. There's a systolic component, and obviously there's a diastolic component. It's continuous to and fro, a friction rub happening all the time. Obviously that sounds a lot different than all the other valvular murmurs we talked about. Here's the Kussmaul sign they're going to have: increased right atrial pressure with inspiration, not the normal decrease. Hepatomegaly and ascites. Blood can't fill. It's going to get backed up. Liver, ascites, abdominal swelling. Here is the Kussmaul sign on the bottom here. Here's your right atrial pressure. Here's your inspiration, and that right atrial pressure goes up with pericarditis. Pericardial effusion and tamponade. Now we're going to talk about fluid getting into the pericardial sac. Before it was pericardial or pericarditis, inflammation of the actual pericardial tissue itself. Now we're going to talk about getting fluid into the pericardial space and what can happen. Again, chest pain, pericardial friction rub are going to happen again because it's going to sound and act like pericarditis, but the etiology is a little bit different. May develop slowly and be asymptomatic. Sudden filling can have big consequences by limiting vascular filling. This is your pericardial tamponade. You have all this fluid pushing down the heart now. As the heart squeezes, does the heart get smaller or bigger when the heart squeezes? Smaller. So all that fluid is now all over the heart. It's pushing down the heart. Can the heart pop open again? No, because all that fluid that gets into the area with every beat. It can't relax. It can't open up again because of all the fluid in the pericardial sac now. They can have shortness of breath due to the backflow of all the blood. This is the important part about pericardial effusion. They have this thing called Beck's triad. Hypotension, low blood pressure because nothing can leave the heart because they're having problems filling the heart. Elevated JVP. We talked about why that happens. Why do they get muffled heart sounds? There's fluid all over the heart. You can't hear very well through liquid. So when you go to listen, it's going to sound muffled because you're listening through liquid. There's fluid there. That shouldn't be there normally, and you'll hear muffled sounds. You have a question?
Can you explain why hypotension would occur?
We have a filling problem, so we can't fill the heart very well. And we're going to have issues squeezing, so less blood is going to leave the heart. If there's less blood leaving the heart, less volume, therefore less pressure. They may also have a paradoxical pulse, where one beat will be a normal feeling on where you feel for the pulse. The next one's going to be diminished. And the next one will be bounding again, and the next one's diminished. So it's a paradoxical pulse. Any cause of pericarditis can cause a pericardial effusion. So we're not going to repeat any of the etiologies because they're all the same. What's the biggest etiology for pericarditis or pericardial effusion now? Viruses, infection beforehand. Okay, so with a sudden addition of fluid in that pericardial space, pericardial pressure can increase. And remember, the right side of the heart doesn't have very high pressures. The left side does, but the right doesn't. So if this pericardial pressure pushing down on the heart exceeds the right ventricular pressure, that right ventricle can't pop open, and you get backflow up into the IVC, back down to the liver, because the right ventricle now can't open because of the effusion. All that fluid is compressing the heart. The right ventricle can't overcome it, and it gets compressed. Reduced filling, that's the big issue. Filling is the problem. It's not a pump problem, it's not problem leaving. The problem is filling, it can't fill. And what I said here on the bottom is kind of what we just talked about. So clinical manifestations, and I think we're almost done with this section. Yep, this is the last one. So shortness of breath, retention in cardiac output, a reduction in cardiac output may also be due to, again, pulmonary edema. Elevated JVP, it's going to alter the atrial filling, and we'll see what happens on the right side of the heart. They lose their Y descent in the setting of this elevated JVP. Hypotension, reduced cardiac output. Less blood is leaving the heart. Going to cause less blood, less pressure in the system, and it drops. Paradoxical pulse, arterial systolic pressure normally drops with inspiration. Again, depending on how you're breathing, it's going to alter the pulses, inspiration, expiration. You guys know that? Remember, listen to the pulse while they're breathing, it slows down and picks up and everything. Muffled heart sound, pericardial fluid in the way. Let's take a break. Come back at 10:55. Yeah. Okay, so we just reviewed feeding the heart muscle via coronary artery disease. We talked about how the heart can be affected by the pericardium, pericardial sac around the heart. Now let's move on to the actual vessels in the periphery outside the heart. So let's talk about our regulation of that. This looks like a lot of reading. Most of it is just review from physio. Anything that alters the output of the pump. So what parameter of hemodynamics are we talking about mainly when we talk about pressure changes? Afterload, preload, or contractility when it comes to pressure? Afterload is altered by pressures. Preload is altered by volumes. Okay? So we're altering the resistance in the vessels. It's going to translate to the heart because the heart's got to pump against it. Okay? The size of the vessel is regulated by vasodilator metabolites. Okay, they make the cells, the vessels either bigger or smaller, depending on what's going on. And the vasomotor nerves are regulated by feedbacks with carotid sinus and your aortic arch baroreceptors. They also feed into what's going on in the periphery to tell the brain this is what's going on in our vessels. Do we need to cause some constriction to get our blood pressure up? Or do we need to dilate to get our blood pressure down? So our metabolites, carbon dioxide, potassium, adenosine, rise in temperature, fall in pH have a vasodilator effect. So when you're exercising, you want your vessels to dilate, temperature goes up. Remember, we have the muscle pump, shivering causes our body heat to go up. Humans are not very efficient when it comes to energy. Most of our production is lost as heat. That's why we get so hot when we exercise. It helps vasodilation, helps with sweating. Think about other reasons why we want vasodilation. All this blood flow to our muscles, we need vasodilation to happen for that. Autoregulation. Okay, what two structures or systems have autoregulation? Brain and kidney. So we have to have that going on as well to maintain constant flow through the brain, constant flow through the kidneys. What else is there? Substances secreted by the endothelium. Again, shear stress is the big thing. Stretch of that vessel due to volume. Getting overloaded. Inflammatory mediators as well all come from the endothelium when it's under damage and stress. Prostaglandins and thromboxanes. Okay, these come from the platelets, the thromboxane A2. And by platelets, from their common precursor, here's your arachidonic acid. Coming there eventually. Okay, thromboxane A2, platelet aggregation and vasoconstriction. But prostacyclin promotes vasodilation, and the balance between these two factors help maintain your vessel diameter. Now, when we get a clot forming, we keep the clot from extending due to this ability to vasoconstrict and vasodilate. We can keep that plaque from extending on beyond the point of injury. The balance can be shifted by giving low doses of aspirin. Aspirin produces irreversible inhibition of your cyclooxygenase, the COX pathway. So chronic administration of aspirin helps reduce thromboxane A2. Here's our nitric oxide. Okay, nitric oxide is the most potent vasodilator that we have. So anything that has an issue with nitric oxide, anything causing alterations in nitric oxide, what will they not be able to do? Vasodilate. If they can't vasodilate, what's going to happen to their blood pressure? Going to go up. So nitric oxide, alterations in nitric oxide functions can alter your blood pressure because you can't dilate. Don't worry about where they're found. But it's formed, mediates relaxation of smooth muscle. That's the big thing to know with nitric oxide. Major regulator of blood flow. Nitric oxide is acting in a chronic fashion to help keep the vascular system dilated. So they did a test where they take a blood pressure cuff, they put it on your arm, and they pump it up till they occlude the vessel so that no blood flow gets to the arm. And they leave it on there for 5 minutes. And after 5 minutes, they undo the bladder of the blood pressure cuff, blood flow gets resumed back to the arm, and they measure nitric oxide function when that happens to help with the hyperemia from the ischemia for the area. The blood vessels dilate really big to allow more blood to get back to the area to help. Endothelins. Okay, they produce a thing called endothelin-1. This is a potent vasoconstrictor. So nitric oxide, vasodilator. Endothelin-1 is a vasoconstrictor. Found in all types of different cells. The indication is that this ET1 may contribute to the remodeling. So we had talked the other day about when the heart gets damaged, endothelin-1 comes out a little bit and starts poking holes in the myocardium. When you start poking holes in it, the integrity of the muscle gets weaker. It's like if you build a wall and you put holes all in the wall, all the pieces around it have to support more weight because you removed part of the structure. Same thing happens in the myocardium, and endothelin-1 is responsible for that. Pokes holes in it like the apoptosis and less muscle. Circulating hormones are principal vasoconstrictors, epi and norepi, principal vasodilators, VIP, anything with a kinin, bradykinin, and your natriuretic peptides. BNP is the big one. We also learned about ANP as well, but BNP is the big one. So the kinins are your bradykinin and your lysyl bradykinin. But remember, just remember, these are vasodilators. That's the big thing to remember with these things. They're vasodilators. Here's our natriuretic hormones. The big one is the BNP, originally isolated from the brain, but they found that the ventricles also secrete it when they are volume overloaded. When the ventricles start to stretch because there's too much volume of blood in the system, they stretch to produce BNP, which then goes to the kidneys to produce natriuresis, so we can get the weight off, get the fluid off, get it out of the body. That's all I want you to know for that one. Vasomotor system, discharge of noradrenergic. What type of nervous system is that? Adrenergic. Sympathetic. Okay, so if we're activating our sympathetic nervous system, arteriolar constriction, which leads to increased blood pressure. Makes sense. We need our cardiac output to go up to whatever we got to do. Also inhibits the effect of vagal stimulation, which is going to slow the heart rate and reduce cardiac output. So we're going to speed up the sympathetic system, but also wear down the parasympathetic so it doesn't work as much. So the sympathetic takes over. So it increases blood pressure by force and rate of cardiac contraction. So the squeeze is going to be enhanced with the betas agonist, and the rate is going to go up as well. Control of this discharge is from the baroreceptor. So when you stand up too fast and you get a little bit lightheaded for a second, that is waiting for your baroreceptor to trigger your brain to say, hey, we need something, and your sympathetic system kicks in, blood pressure spikes a little bit, and you don't get dizzy, and the dizziness goes away. Okay. Baroreceptor response also causes some endocrine changes, some renin secretion, and obviously your vasopressin as well. Ways to get, remember, with low effective circulating volume, how do we reduce that, or how do we overcome that? RAS system comes out, vasopressin for vasoconstriction comes out. Again, we're trying to get that blood pressure back up. Okay, atherosclerosis. We talked about this a little bit whenever it relates to coronary artery disease. But here we're going to talk about atherosclerosis as it relates to just vessels in the body. If you have atherosclerosis in your cerebral vessels, what are you going to get? Stroke. Okay, they're all the same. If you have atherosclerosis in your calf, in the arteries that feed your leg muscles, you're going to get that intermittent claudication, the pain there because you don't have enough occlusion in that area. Or you get some peripheral arterial disease because the blood flow to the legs is altered. These are all atherosclerotic changes. It just depends on what vessel feeds the structure. If it's in the coronary arteries, it's coronary artery disease causing an MI. That's all we're talking about. Obviously, going to affect large and medium-sized arteries. So macrovascular. Or in societies with cholesterol-rich foodstuffs. A lot of cholesterol in the food. Processed, ultra-processed stuff. There's genetic and obviously environmental factors that deal with atherosclerosis as well. Characterized, again, localized fibrous thickening of the arterial wall, lipid-infiltrated plaques, so those foam cells, the LDLs get in there, and that may eventually calcify. They'll harden over, they'll endothelialize, and that's our body repairing that rupture. Old plaques are prone to ulceration and rupture, and when they crack, all the formation of that thrombi, the repair is going to happen all over again, and now you can potentially occlude that vessel. So it leads to vascular insufficiency of the limbs. If it happens in the renal artery, renal circulation gets altered. So let's say you have atherosclerosis of the right renal artery. Let's say it gets occluded. So that right renal artery, there's no blood getting through, or there's less blood getting through than normal. That right kidney, what is that kidney going to suspect? It's getting less blood flow. What area of the kidney is going to sense that low blood flow? The macula densa, right? So the macula densa is going to sense this low effective circulating volume because you have atherosclerosis of the renal artery. So what's the macula densa going to release? Renin. And what's the end result of this renin cascade? Well, what's the end result of the renin? What's the last hormone going to be released? Aldosterone. What does aldosterone do in the kidney? Bring in sodium and water, secrete potassium. So we're going to bring in water and sodium. What's going to happen to my blood pressure when that happens? Goes up. Do I really have high blood pressure? No, I have renal artery stenosis due to atherosclerosis. You put a renal artery stent in there, you open it up, and your pressure goes back down to normal. That's a way of what atherosclerosis, when it affects the kidney, that's what it can do. Also, you can get some dilations or aneurysms, and those can break and rupture and cause a bunch of problems. Yes?
As far as like presentation goes, how would you know like it's not just normal high blood pressure versus
So when you treat them, you don't know at first. So they're coming with, I have high blood pressure, my blood pressure is 170. You're going to give them medication. Medication's not going to touch it. After like a month, like, well, what's your blood pressure like? Oh, it's still high. So if someone's unresponsive to blood pressure meds, then you start looking at other causes. One of them is renal artery stenosis. The other one's like hyperaldosteronism, like from a tumor. There's other things, but we'll get to those in a second. Actually, we'll have some slides coming up later for hypertension. Reasons for it: high LDL, which is the bad one. Here's our shear stress again. High blood pressure causing these damages to the vessel wall, causing shear injury. Whenever you have the intimal damage, fatty streaks are going to form, and you start getting all those issues. LDLs are oxidized, and they get stuck in there. We get proteins. Here's your C-reactive protein coming out due to evidence of inflammation. LDLs are recognized by these scavenger receptors that are expressed on macrophages, and they stimulate inflammation, and they drive the atherosclerosis. So these scavengers are all made up of these oxidized LDLs. We talk about oxidation. We don't like free radicals and all that stuff. They cause a lot of problems. Okay, and this is what causes these foam cells to occur. LDLs and macrophages together make the foam cell. Okay, these foam cells coalesce later on, and they appear as your fatty streaks. Okay, so you all have a little bit of fatty streak in your aorta right now, at least, just from being 20 plus years old. And then the aorta, remember, is under constant pressure all the time, so you will get a little bit of fatty streaks first in the aorta. And it goes from there. Coronary arteries in the second decade, cerebral arteries in the third and fourth decade. Okay. The big thing with oxidized LDLs, inhibition of nitric oxide production. So we mentioned before, when you have these LDLs, it's going to alter nitric oxide function. Anything that alters nitric oxide function is going to have a problem with vasodilation. So the vascular smooth muscle cells, where these foam cells are stimulated, move from the media to the intima, and they start building into the intimal layer, and it provides some more of the bulk of the occlusion due to the intimal layer thickening. Smooth muscle cells take up oxidized LDL, they become foam cells. Lipids accumulate intracellularly and extracellularly. As plaques mature, we get that fibrous cap over them. And that's what we want to keep stable, that plaque. How do you keep the plaque stable if you know they already have coronary artery disease? What do you think you're going to be doing to that patient? You don't have to know any medicine for this. You probably know it already. Blood pressure management, cholesterol management, stop smoking, get your sugar under control, and watch your diet. Everyone gets the same thing. They all get the same thing. It's secondary prevention. You know they already had it. Now we want to either primary prevention, we want to prevent the first heart attack, or they already had a heart attack. Now you want to prevent the second one from happening. You got to get them under control. Get that blood pressure control, cholesterol, diabetes, smoking, and then your diet. Those are the biggest things you'll be dealing with most of the time in your practices are those things. So again, nitric oxide is defective is the main summary of this one. Nitric oxide doesn't work anymore, and it's due to the oxidized LDLs. Here's a little bit about dietary cholesterol and other lipids. All the bad ones are these ones. These are the bad ones. Chylomicrons are kind of like what's taken up by the liver, but then they get smaller and smaller. These very low density lipoproteins, intermediate, low density, basically the low density lipoproteins are the bad ones. They're going to promote atherosclerosis. That's why you don't want high LDLs because they're going to be floating around contributing to these foam cells, making the plaques thicker, unstable, prone to cracking. That's why you get the cholesterol under control. The HDL is the good cholesterol. It's going to scavenge cholesterol, bring it back to the liver so that we can put it into the feces and you can get rid of the cholesterol. So you want HDL to be as high as possible because it's a scavenger. It's going to bring the cholesterols back to the liver out of circulation. So you want that as high. So if someone's got a very, very high HDL you want above 40. That's the key number there for HDL. The higher that number is, the better. The only way to get HDL up is exercise. That's it. So that's why you have to tell your patients to exercise, get them moving. It's going to help with the HDLs. A high HDL will offset a high LDL. So if their LDL is 130, but the HDLs are 50 to 60, you're fine, don't change anything, you're okay. You can go from there. So what are some clinical manifestations of atherosclerosis? Generally asymptomatic until a complication arises. If it's in the coronary arteries, greater than 75% occlusion will cause angina pectoris, so your chest pain. So again, if the atherosclerosis is in the cardiac vessels, 75% occlusion, angina pectoris. If it's in the cerebral circulation, they cause thrombotic strokes to happen. Clot gets bigger and bigger, then it occludes the vessel and whatever part of the brain that artery is feeding, you're going to have problems later on. If the atherosclerosis occurs in the abdominal aorta, they're going to get aneurysmal dilation and rupture, so a ruptured abdominal aorta. What test do you guys do in PD to test for the aorta size? And what do you feel for? Pulsations, right? You're seeing, are they having a dilated aorta? That's why you're trying to get your measurement to see the width of that aorta as best as you can. Because when it starts to dilate, it could be an aneurysm. And those are very prone to rupture. And they start bleeding internally like crazy. If it's in the renal vessels, renal vascular hypertension. That's that renal artery stenosis, lack of blood flow to a kidney. The kidney thinks, oh, I got less blood, let's kick some renin out, and it brings your blood pressure really high. If it's affecting the legs, intermittent claudication. So patient will start walking and they get to a certain intensity, start getting pain in the calves because there's ischemia to the muscles because the demand of oxygen went up, but the supply cannot meet it. When you get a mismatch, ischemia occurs, and it's going to happen in the leg muscles and the calves, and it causes pain, so they stop walking, and the pain goes away. That's intermittent claudication due to occlusion of the vessels in the legs, obviously. If the circulation in the limb is severely compromised, then you can get gangrene. Remember we talked about wet and dry gangrene. Which one is due to vessel occlusion, lack of blood flow to an area? Dry gangrene. So they're going to get dry gangrene because lack of blood flow to an area. Who here knows people who have uncontrolled diabetes? What happened to their feet and their ankles? They get ulcers and pressure sores and wounds. Why? There's no blood supply in their legs because of the diabetes. They can't heal because there's no blood supply in the legs. So any damage that gets done. Due to lack of blood supply, they can't feel anything. They got peripheral neuropathies. So they can't feel when they hurt themselves, and then they can't heal anything. So they get wounds like crazy. You got to wear special things. So again, this all matters where the occlusion occurs. So if someone's now, the other important thing, if someone is coming in, let's say with intermittent claudication, they say, I go for a walk, I walk my dog, after about 5 minutes, my calves are hurt, I gotta sit down. If they have atherosclerosis in one area, assume they have it in other places as well. It doesn't just go to one area. It affects globally. Obviously, the big area is the shear forces, so any of those bifurcations in a vessel. That's where a lot of it's going to happen. But again, it can happen anywhere. If someone's coming with intermittent claudication, I am stress testing them. I'm getting an EKG. I'm going to make sure what the heart is okay. Because they have issues other places in the vasculature. It may happen in the heart as well. Check the heart. Risk factors. Okay. Estrogen. This is why women live longer. They have estrogen. Estrogen is cardioprotective. That's why, so if you're asking family history, if your mother or father died of a heart attack, what's the cutoff in ages? For a male, my father, he had a heart attack. How old would he have to be for me significant for me? Less than 55, and then 65 for the female. Why? Because they have estrogen. That's going to protect them. That's why when women have menopause, the estrogen drops. Now their risk for high blood pressure and hypertension skyrocket because they're missing the estrogen. So you put them on HRT, and that helps with the blood pressure and other things. So that is the deal with estrogen. Homocysteine. You get some increased plasma levels. It's a marker of inflammation. With homocysteine, if you ever hear this whole the MTHFR gene, if you hear people who can't metabolize folate or any issues with that, if you ever hear it, it's like an MTHFR. Look it up. It's pretty significant. Like some people can't do folic acid or they can't synthesize it very well, so you have to supplement yourself, and you feel a lot better when you do. But this is what they're talking about. All these things have to do with this MTHFR gene. It can alter your homocysteine levels, which is a marker of what? What is homocysteine? Inflammation. So we know we're inflamed. What's going on? Also, accelerated atherosclerosis as well. Smoking. Okay, 70% increase in death from ischemic heart disease compared to non-smokers. And again, endothelial damage, but carbon monoxide-induced hypoxia due to continuous smoking. Make sure you ask your patient, don't just say, do you currently smoke? What if I quit 3 months ago? I don't smoke now. You gotta say, have you ever smoked? Oh yeah, I smoked for 40 years, 3 packs a day. Oh yeah, but I quit 3 weeks ago, so I'm good now, right? No, you're not. Ask these questions. Lowering cholesterol, trig levels, increasing HDL, we talked about that. The cholesterol changes can help stabilize the plaque, and in some cases, they can reverse it. So really aggressive, that's why we're so aggressive with cholesterol, getting it down. Because over time, there's been studies that have shown there can be some reversal of these plaques with really, really good cholesterol management. Usually when someone comes in, if they have high blood pressure or high cholesterol, diabetes, and this is the first time I've diagnosed it, and they're not really, really high, I'll say, listen, I'll give you 3 months. Make dietary changes, get moving, start exercising. Let's see what happens in 3 months. This way you give them a chance. Like, I don't want to give you medicine right now, but let's see what you can do on your own. Make some lifestyle modifications. We'll recheck you in 3 months. And if they're doing better, then continue it. Don't say diets. Diets are always temporary. Like I'm dieting for something. No, it's lifestyle modification. You got to change the way you eat. It's not a diet, it's temporary. So that's that one. Hypertension is also a risk factor. Okay, increased shear forces is going to promote more atherosclerosis, more plaque buildup, because of the high blood pressure, more shear forces ripping those arteries up. Diabetics, they have a lot of microvascular complications. So when we get to diabetes, diabetes attacks the big vessels and the small vessels. So it's macrovascular and microvascular. It does the little ones too. That's why, you know, if you want to see someone that has bad diabetes or whatnot, look at the hair on the legs. When you're doing your inspection, if they have no hair growth on their toes or their lower legs, what does hair need to grow? Blood. You don't have enough blood, you're not going to support hair growth. You'll see it go away. That means they're having vascular incompetence, lack of blood flow, they're not going to have any hair. Nephrotic syndrome and hypothyroidism are also risk factors for atherosclerosis development. So remember, when we're in this course, we're just talking about atherosclerosis. How does it develop and go on and so forth? When you get to other courses, they're going to say it develops atherosclerosis, they're going to move on. They're not going to go over all this development in some courses. Cardio, they will. But again, they're going to say hypothyroidism leads to atherosclerosis. End of story, move on. Go back to your notes from Pathophys. Okay, now let's talk about hypertension. It's a syndrome, not really a single disease. We classify hypertension as essential or primary hypertension. These are causes unknown. You have high blood pressure, I'll give you some medicine, we'll lower it, but there's no underlying cause. I can't remove something, treat something, and your pressure comes down. It's just high, that's the way it is. Your secondary causes. This is where you know why they have high blood pressure. So here's our renal hypertension. Atherosclerosis of the renal artery, lack of blood flow, all those other fun problems. Cushing syndrome, pheochromocytoma, and estrogen. These are all causes of high blood pressure as well. But they're known causes. Here are the guidelines. You don't need to know from my class, just know there are guidelines. You'll get it in cardio and other classes as well. But normal blood pressure is 120 under 80. Just know that one for now, 120 over 80. And goes from there. Obviously, the higher you are, the greater the stages. So pathogenesis, what causes hypertension? Obviously, increased peripheral vascular resistance. Makes sense. What are we increasing in this case? That afterload goes up because we're increasing peripheral vascular resistance. Afterload goes up. What does our heart have to do now with the increased afterload? Increase your pressure to overcome that, and that's what high blood pressure is in one case. Prolonged increase in cardiac output. Okay, for some reason your heart rate is just going crazy, your heart squeezing harder for a long period of time. Exercise is an intermittent increase in cardiac output. It's heart rate variability, which is why exercise doesn't really cause much damage because the heart rate goes up and down. Increased blood volume, increased blood viscosity. If you go back to first lecture of cardio, we talked about resistance to flow. We only talked about really two major ones. There are three factors that deal with resistance to flow. Two of them we talked about a lot. Length and the diameter. The other variable that we didn't really mention very much is the viscosity of the blood. How thick is the blood? Normally, our blood's the way it is. Conditions that can make the blood thicker, pancytopenia, too much red blood cells. It's going to make the blood thicker. It's going to be harder to move through. Dehydration. If you're dehydrated, you're pulling the water out. So all the red blood cells have a bigger proportion. The blood will get thicker. Sometimes people have like familial hypertriglyceridemia, where their triglycerides are over 1,000, like really, really high triglycerides. That can make your blood more viscous and thicker as well. When that happens, your pressure goes up because it's harder to move thicker, viscous blood. And increased plasma renin activity. That should make sense by now. We talked about this many times today. Presentation, non-specific. They don't know they have high blood pressure until you tell them they have high blood pressure, or they go get checked out and they said, hey, your blood pressure is high. Go see your doctor, see what's going on. Routine screening. Hypertensive retinopathy. Have you guys done that yet in ophtho? Okay, so you'll talk about what changes happen in all the retinal veins and arteries with high blood pressure. They get all the spots, all the bursts, it's like a pizza wheel on the eye because the blood vessels burst. Due to high blood pressure, these are very, very small arteries. They're not made for high pressure, and they pop. You get retinal hemorrhages. Left ventricular hypertrophy, the heart's got to squeeze against that. And if it's untreated and you're doing it every day with every beat, your heart's working out every beat, it's going to get thicker. Cardiac enlargement, bruits happen again, abnormal blood flow across the valves. Atherosclerosis will also, okay, when you guys listen to bruits, you're listening for atherosclerosis buildup in the artery that's causing blood flow to make a noise when it goes by it. That's what a bruit is. If you hear a bruit, that's why you want to listen first before you palpate, right? You have to do it that way first, because if you hear a bruit and you start palpating like crazy, you can break that clot off. And where's that clot going to go? And you cause a stroke. So that's why you don't do that. Okay, so that's what bruits are for. You listen to a bruit in the iliac arteries. When you go down your tree and you're like, listen for bruits with the bell, right? And all the iliac and the femoral, all that stuff. You're listening for atherosclerotic buildup along the artery that's causing turbulent flow, which is a sound. And that's it. Okay, here's one of our great charts. So this is a great one to remember as far as when you're reviewing hypertension. We have high blood pressure. That's going to cause an increased afterload, which we know is going to cause systolic problems because it's a squeeze issue. We have to generate pressure. It's going to cause left ventricular hypertrophy because the heart is squeezing against that afterload every beat. It's going to get thicker, so you get LVH. LVH causes diastolic dysfunction. And here you go, and this is how hypertension can lead to heart failure. This is why you need to control high blood pressure. This is why your patients need to be controlled with blood pressure. Because in 20 to 30 years of uncontrolled high blood pressure, this LVH keeps building up, you're going to put that patient into heart failure because you didn't treat their high blood pressure. The other thing that happens with blood pressure in your patients, they don't feel a difference when they take the blood pressure medicine or not. If you're sick, you take an antibiotic, a day or two later, you feel better. Blood pressure, you have to convince your patient, listen, I need to take this pill every day. Why? Because your pressure's high. Well, I don't feel any different if I take it or I don't take it. So what happens? They start missing doses, and their pressure is going to stay high and cause a lot of problems later on. This graph, in your mind, you want to explain it to your patient. Hey, if you have high blood pressure and you don't treat it, it can cause heart failure. It can cause heart attack and infarction. How does it do that? Well, with hypertension, the increased afterload increases myocardial oxygen demand. The heart has to squeeze harder, therefore it's going to need more oxygen because it's squeezing harder. The oxygen demand has gone up. Now, the other side of this tree is high blood pressure also causes arterial damage. Okay, what do we call it? We mentioned it. What kind of force is it? Shear forces, shear stress. Due to this high blood pressure, constantly hitting the bifurcations. Remember, the blood hits this area, it's continuously hitting that area. That's where it bifurcates. Biggest shear stresses, that's where the injuries happen. So, we get accelerated atherosclerosis because this arterial the epithelium is continuously being damaged. So we get atherosclerosis buildup. If it happens in the coronary arteries, now we have decreased maximal oxygen supply, a decreased myocardial oxygen supply. So with hypertension, we've increased the demands for oxygen by the heart, but because of the atherosclerosis generation, we've also reduced the supply to the heart. So the two ways we've increased the demand and we reduced the supply. So we have a big deficit here, and that's where the ischemia builds up. So if it happens in the coronary vessels, that's why you get MI and so forth. Everyone following along pretty easy? Okay. Again, if it happens in the cerebral vessels, you get an ischemic stroke. If it's in the aorta, aneurysms and dissections. Weakened vessel walls, these cause aneurysms. And again, depending on where it happens, but again, hemorrhagic stroke, nephro issues, retinopathy, aneurysms, ischemic stroke, these are the things that long-standing, untreated blood pressure can cause in your patients. This is why you need to treat blood pressure. You want to prevent any of these things from occurring. Not saying you get all of them, but explain to your patient, if you don't treat it, these are the things that can happen. Again, if you don't treat it, life expectancy can be dropped by 10 to 20 years. Silent killer, again, they don't feel any different. And these are the things that can happen. Again, just a summary of the picture before. Yes?
I have a question. So if you have a patient that started presenting with symptoms of hypertension and they decide to make lifestyle changes probably midway through their treatment, is there a way that they can come off the
Yep.
medication?
So the way you have to take people off blood pressure medicine, remember that just because they're 120/80 with medication, if you stop the medication, they're going to go back up to 140, 150, whatever. If their daily BP logs, now they're trying to get into the hundreds over 60s, now you know your blood pressure medicine is too much. So you start backing off and reduce it by half. Let's monitor your blood pressure for the next couple weeks to see how you're doing. Oh, it's still hovering in 110s, 120s. Okay, maybe we can reduce it a little bit more and see how you do. But that's how you do with blood pressure. You can't just stop it when they're normal because you gotta wait till they come a little bit too low. That means that what they're doing is lowering it, and the medication is lowering it too much as well. So it's all based off their blood pressure. If they're in the 100s all the time, they're getting lightheaded and dizzy, we know that whatever modifications they made, lifestyle, diet, made a difference in their pressure, and you can back off the medicine.
So they can completely stop.
Yep. Same thing with diabetic medication. Diabetes is not permanent. Stop eating. If it's type 2, I'll say that. Type 1's different. Sorry, Lee. Type 2, stop eating. Okay? I'm serious. That's it. Stop eating. That's it. Seriously, stop eating. Management, again, you get a lot more of this in CMS. Beta blockers, calcium channel blockers, diuretics. Here's the big thing. It's not curative. Okay, you're not going to cure high blood pressure. Now, if they have high blood pressure due to renal vascular issues, yes, you can cure that. But primary hypertension, there's no cure. Secondaries, you have a reason, therefore you can cure those. So what are some reasons people could have high blood pressure without actually having real high blood pressure? Coarctation of the aorta. This is a congenital problem. You get narrowing of the aorta just distal to the origin of the left subclavian artery. So we get a occlusion. That's going to raise your pressure, the afterload placed on the heart. Because we have the aortic pressure, but now you have the subclavian occlusion, which is another area for blockage to raise your pressure that the heart has to squeeze against. So in the coarctation of the aorta is another reason for a curative reason for high blood pressure. Salt sensitivity, about 30% of whites with normal renal function and normal blood pressure are salt sensitive, compared to 55% of African Americans with essential hypertension. Why are blacks more sensitive to salt? Unknown reason, but blood pressure will skyrocket more depending on salt in the food versus whites. So everyone really doesn't eat salt in their food. Don't add salt, it's already there. Renal abnormalities, here's our renal artery constriction, renal artery stenosis. It's a blockage of the artery, tricking the body into thinking we have low pressure, and you activate the RAS system. Renin-angiotensin abnormalities. This is stimulated by estrogens. So what happens is estrogen increases angiotensin secreted from the liver, more angiotensin coming out, more aldosterone later. Oral contraceptives with large amounts of estrogen can cause high blood pressure. So if anyone's on a high estrogen birth control and their blood pressure is very high, it could be due to the estrogen in the birth control pill causing it to go up. Adrenal disorders. This is primary hyperaldosteronism. Yes?
Why would estrogen raise blood pressure if it's supposed to be like cardio?
That part, the cardiac has to do more with the cholesterol side of things, not the blood pressure side.
So
Question?
why do women, like you said that,
The estrogen is more cardiac for the cholesterol. Yes, it does raise their blood pressure, so you have to be careful for that. I'm sorry. So they go on estrogen for other reasons besides just the cardioprotective part. Bone loss is big when estrogen drops. So they go on the replacement, but if their pressure is too high, then they reduce their estrogen off the pill, whatever they're on, reduce the dose. So that's hyperaldosteronism. If you have too much aldosterone, too much sodium and water resorption, increases your pressure. Glucocorticoid excess, that's your cortisols. That being high can also, obviously through sympathetic nervous stimulation, will also make your blood pressure go up as well. Obesity by itself, there's a link between obesity and hypertension. Insulin resistance, hyperlipidemia are more prevalent with hypertension in these patients. This is that metabolic syndrome. It's obesity, high blood pressure, high cholesterol. You can throw some diabetes in there as well. But again, with obesity, it leads to an insulin resistance, which is probably what causes the whole entire cascade from happening, or for happening. This is a great sheet for you guys to keep when you start learning all your cardiac drugs with Dr. Wood and Professor Muniz and cardio. Just a great little cheat sheet to look at all the different drugs. And we'll stop here. And we'll do this last little bit tomorrow, and we'll do our review. Test is next Wednesday. It's like 70%, 65% cardio, 20, 30% of the inflammation and infection stuff. Okay, I'll see you guys tomorrow.